right. Welcome everyone to the Q2 Samya Stumo Fellowship presentations. Thank you to all the mentors who have joined us, and thank you to the fellows who are going to be presenting, and all the ThinkWell staff and the board members who are here with us to listen to the presentations. So in Q2, we focused a lot on project management with the fellows, and we've taught them skills in terms of how do you think about what types of planning skills do you need, what types of budgeting skills do you need, and what types of implementation, pre-implementation, and strategy skills do you need. And each of the fellows have been preparing for a test that they will conduct for their projects in Q3 and 4. And these presentations are simply 15 to 20-minute presentations sharing what this initial Q3 and 4 test will look like. Every fellow has a different project. Every fellow has a different process. So we invite you all to listen to each individual and unique perspective that they bring, and also ask questions at the end. Right now, I have only enabled questions for the mentors and the board members, but anyone who wants to ask a question in the chat is more than welcome to, and I'll make sure there's either time for that or that the questions get sent to the fellows if there's not enough time. So without further ado, I would love to start with Rukshan, who is our first presenter today. Take it away, Rukshan.
Hello, everyone. I'm Rukshan Fahmi, one of the Samya Stumo Fellows. So today I'm going to share my presentation with you, which is about, So my presentation is about developing behavioral change communication material for lower-income parents of hydrocephalic children of Bangladesh, because that's where I'm from Bangladesh. So the goals of my project is to focus on developing behavioral change communication materials for lower-income parents of hydrocephalic children by identifying the information they need to reach the health system on time for their hydrocephalic babies. So hydrocephalus is not a very common disease. So let me give you a small introduction about it. So it's obviously related to your neurology. It's a neurological disease. So when the pathway of the cerebrospinal fluid gets blocked inside your brain, so it keeps accumulating, and as a result, your head circumference gets enlarged. So that's what happens. This is a picture of the hydrocephalic baby. So you can already guess, I guess, that when it creates pressure on your brain can function, eventually leads to disability and to death. So it's a very critical condition that needs attention at the earliest stage of disease. So unfortunately, for the prevalence of disease, there are no published records on the prevalence of this disease in Bangladesh. Though their studies are informing us that lower-income countries are struggling with the disease burden, there are hardly any data available on South Asian countries. So as for the global prevalence rate, it is 88 children per 100,000 births. As for behavioral change communication materials, so these are materials you can often see in the streets and other areas. You will see them as posters or digital medias, but compared to other posters or any kind of medias, any kind of channels that are trying to reach you, behavioral change communication materials tries to nudge you to adapt to healthy behavior. They won't force you, they won't intimidate you, they will just positively nudge you. That's why I have chosen behavioral change communication, or BCC materials, to be say in short. And as for the gaps that shaped my project goal, first of all, studies have presented that lower income parents usually come late to the health facilities to treat their hydrocephalic babies. So you can guess the obvious reasons: education, economics. So there are numerous factors, which are not good to focus for now. But what happens is, eventually when they reach the health facilities, the child is diagnosed late. And even the late diagnosis cannot inhibit the disability and death of the child. As you can remember from the previous picture, the head circumference keeps enlarging and the water keeps accumulating. So you can guess the burden of that disease. So what happens in case of my country, I haven't found much published BCC materials targeting these lower income parents about pediatric hydrocephalus. So what happens is that's why I chose BCC materials. That okay, this can be a very good to help these lower income parents. So I want to share two things when it comes through my project goal. I'm working on my formative research to understand this target population, and that's when I came across this department head of pediatric neurosurgery from one of the largest tertiary level hospitals of Bangladesh. That's National Institute of Neuroscience, because they are the ones who are actually dealing with this kind of patients. So the department head told me that even when they come in this hospital, they remain skeptical. The lower income parents, so they're a bit confused. So when they leave and they seek care from traditional providers, but they find no improvement over years. They return to us, but alas, it's a bit late. So that's a gap that inspired me to look into this. There is another thing another inspirational quote I must say that I found from assistant professor of DMCH, another largest tertiary level hospital of Bangladesh, Dhaka Medical College Hospital. So she's from the neurosurgery department, and she told me that it's a wonderful initiative. It's a wonderful work you're doing. She had observed a child who was 8 years old, but she had come late again, unfortunately. But that child was so intelligent and she had so much prospects. But it was heartbreaking to see that child die. If her parents had brought her earlier, but they just didn't know how to come. And so that's why I think BCC material will be a very helpful way to reach this. My planning process, I mentioned you earlier that I was working on the formative research phase. So through formative research, I will identify the messages that parents of hydrocephalic children prefer by exploring the challenges they face reaching the health facilities. So I need to understand their challenges prior jumping toward with some messages. And then I'll finalize the messages. And how will I do it? I will test and pretest the developed messages from the formative research to understand the level of comprehensibility and acceptability of it among the target population. I'm not just going to come with some messages and print it. I need to understand the comprehensibility and acceptability among the target population. Formative research in quarter two, which is near to the end in March. Till now, I have developed protocols, guidelines. In short, I have prepared for the phase, formative research. And then currently, I'm trying to acquire permission from the hospital authorities. So that's what I'm doing currently. And then April, I will hopefully conduct the formative research among my target population, which consists of the lower income parents of hydrocephalic children, doctors, and nurses and others. And then I will analyze my message by the end of third quarter three, which is in May. And then for finalizing the messages, which will start in middle of quarter three and will finish in four, I'll prepare the messages for the target population, test them again because you can never do enough research. You need to do it simultaneously to have a comprehensive understanding so that you don't make mistake. And then I will present it with you and share what I have found in quarter four. um, as you can guess, I guess that you're comprehending that who are my stakeholders? Who am I going to address? Of course, the parents of hydrocephalic children, they're the first ones I'm going of my in my list of target population. And from the side of government,
Can you hear us, Rukshan? There might be a quick connection error here.
affordable from them. And same is applicable for DMCH. So as for the hospitals, I want to detail you about the stakeholders who are those who are department heads, ethical review board members, physicians dealing with hydrocephalic children, and nurses in charge of handling the hydrocephalic children. Because these people are intimately working with these patients, they can give me a fair idea what's happening in their lives. And of course, I'm going to work intimately with them. That's why I shared their list with you. So while I approach some of the stakeholders, one thing I came to notice that none of these institutions could provide proper instructions about the necessary steps that I need to follow to acquire the research approvals. So it took more time than expected. While I was expecting it by the end of March, I think it's going to take the first week of April. But still, I'm not going to say it negative because despite all the hassles, I came to appreciate these stakeholders. And you know why? Because they may not be the best persons to guide me about getting the ethical approvals from a project. But each and every of them tried their level best to help me by any means they could. For example, the both of the department heads of these two institutions told me, "Oh, you need to have a permission letter from me." They could have just avoided it or affronted me for not getting one, but instead they guided me line by line on how to develop the permission letter and whom to approach to get the permission. And they give me their full blessings and support. So that's a huge thing for me. And as for the community people, how can we forget them? Last but not the least. As for my implementation plan, I hope to conduct research after it's over, of course, I'm going to approach the sub to approach our foundations to support this project so it does not stop in the middle. And then I hope to conduct research on preferred mode of communication to receive the messages, because just because there are messages doesn't mean that I will develop posters and video materials. I need to also do research on that. And then I need to approach the communication material developers to design and develop an outline of the material, because without them I just cannot put everything in a plate and expect everyone to receive it. So I need their help. And of course I will never forget my government, because without their help I can never test the acceptability of the material in the community people. I cannot even penetrate inside the community, let alone pre-testing it. And then I will keep addressing the comments and modifying the material and keep retesting it among the community people. Because as I mentioned earlier, you can never do enough research. There's always something to learn every time. And then I'll collaborate with the government to pilot the material in different parts of the country, because I cannot expect in all equal inequity in every part of the country. Like I cannot expect to have television from everyone or internet in every household. So I need to understand the vibe when it comes to communication materials. And then post analyzing, finalizing the material, hopefully with the collaboration of government support from their health system, I will disperse the material in different parts of the country. And then comes to measuring the impact of my project. So after a certain duration of implementation, like 2 to 5 years, because it all depends on the budget and the time I will be allocated, of course. But then with government collaboration, we will be able to measure the impact. Like, what do I mean by the impact? Increased awareness about appropriate healthcare for hydrocephalus among parents, because that's what I'm targeting. That I need to understand how much they have become aware about this disease. But I will do it by analyzing data, and of course, I need government's permission, approval, and help for that. If the program can be adopted and implemented by the government health system, because without them, I can never take another step ahead. So that's my plan till now. Let's hope for the best. Thank you. If you have any questions, I'll be happy to answer.
Thank you, Rakshan. So your mentors and the board members are able to ask questions out loud. Get off mute. You're welcome to ask any questions. Anyone else who has a question, feel free to type it in the chat, and then we can get them answered. Shamima, do you have any thoughts?
Not like a question, Mira. And thank you, Ruksan, for making this nice presentation. I'm just would add on like Ruksan that this is a like a very complex and tough thing she took up, and she's doing like a really good in terms of learning by doing. And I really become really very much like happy and to see how she is going out to these hospitals like a day after day and managing everything to pull together the permissions, ethical clearances, and working with them closely, like word to word or sentence to sentence. That's really amazing, and I appreciate Ruksan to take that initiative, because it's a tough learning. Honestly speaking, it's very tough learning, and I greatly appreciate that she took the challenge, and she's doing very well. Thank you.
Congratulations, Rukshan. Marcelina, you're able to get off mute now.
Great, thank you. And Roxanne, excellent job. Very clear, confident presentation. Your passion for the work really shows. So well done. I won't repeat what Shamima just said. I will add going forward, you did mention for the longer term, you of course need to collaborate with the government. One thought to add to that is to also collaborate with development partner organizations like WHO or UNICEF, who I know think well Bangladesh has good relationship with them as well. You can't do everything yourself in the beyond this phase probably. So institutionalizing this with another partner who can take on the good work that you've started will be something important as you go forward. All the best with that. Over.
Congrats, Rukshan. Anyone else want to ask a question, make a comment? All right. Great work, Rukshan.
Thank you.
Next on deck, we have Nadine. So Nadine, please go ahead and get your presentation ready.
Mira, before Nadine goes ahead,
Yeah.
can I ask a question?
Of course you can. Hi, Anne.
Hi, how are you? So
Good.
thank you very much, Rukshan, for your really interesting presentation. I had a question about targeting and how your BCC materials will reach your targeted audience, which is a very niche audience of parents with children with hydrocephalus. So how would you go about making sure that, you're able really to target the right audience with your BCC messaging? Over.
So, as I had mentioned earlier, I cannot be sure about how to reach this population because in Bangladesh, some of the people may have access to internet, television, or people like us. They have access to every mode of communication. But then there are people who live at who are living in the marginalized community. So I cannot tell for sure that how am I going to reach that. That's why I'm going to do research at different parts of the community, and that's why I need help, my government's help, because without them, how am I going to earn their trust? So that's my plan for now, that I will do research. But before that, I need to finalize my message in this fellowship. By the end of this fellowship program, then I will focus on this part, the communicate, how to reach these people through this communication, the mode of communication. That's for me. That's my plan for now. Let's hope for the best.
All right. Thank you, Rukshan. That's something we can think more together with your mentors as well as the months go along. Great. Thank you, Anne, for the question. Nadine, are you ready? Okay, great. Go ahead and get off mute and start your presentation.
Hello, good evening to everyone. Good morning to where you are. It's 8 p.m. where I am in the Philippines. I'm inside my clinic in the Lima Mother Support Center. I have really been trying to work on this presentation, and I hope thank you so much for listening, and I hope you can see how much we've worked and how much we've grown through the fellowship. So again, our project is called the Ugnayang Nanay, or the Mother Connection. Through this project, I want to build enabling environments for breastfeeding by creating a strong network of breastfeeding champions, a chain of mother support centers, and strong local policies to protect, promote, and support breastfeeding. Before I could do that, us breastfeeding advocates have a problem of creating these enabling environments. We create innovative and effective breastfeeding support programs, but we lack the skills and resources to scale these up. This hinders us to reach more mothers. So we are limited by our capacity and our resources. So through the fellowship, through the organizational development, I would like to reestablish establish Modern Nanays of Mindanao and create and invest in its systems so that we can multiply more breastfeeding champions to create these enabling environments in the island of Mindanao. So this presentation will define the gaps. Why did I choose this project? What are my goals? What are the strategies? Who are the stakeholders? And how will I plan to test it, and how I would record the impact? So this is the story about us, the Modern Nanays of Mindanao. We are a group of young mothers who came together for a common mission to help other mothers. We are busy building our own families, but the heart and the compassion of these women to help and support other mothers to make no mom feel alone is the bond that we share, and that's why we created this group for the mothers in Mindanao. And these are the people that I want to build the capacities of, and these are the people I want to journey with me to create these enabling environments for every child in Mindanao, in the Philippines, and in the world. So excuse me, somebody's calling. Starting the fellowship, I applied because I was at a loss at how I would lead the organization. We have made bounds in the advocacy, but we found ourselves struggling and burnt out. And I felt the weight of that responsibility as the founder. I started the advocacy when I was a young mom of 22 years old back in 2012 when I planted the seeds of advocacy with my breast friends. We were college friends who shared the advocacy to a few moms, and then we just kept on by raising awareness from 2013 to 2015. And then by 2016, people outside my personal circle came together. So these are the Modern Nanays of Mindanao coming together and created these amazing events and enabling environments to bring mothers together in Cagayan de Oro City. By 2017 and 2019, we gained a lot of recognition, awards, and projects. We were awarded as one of the 10 accomplished youth organizations in the Philippines. We were one of the awarded by the Breastfeeding Advocates of the Philippine Pediatric Society in 2017. We were even able to respond to the Marawi siege by creating Malong Care Packs and then setting up an ideal women and infant child care spaces, which even the government was not able to do. We had our first international non-government organization partnership and handled around 1.5 million project and reached 2,000 pregnant women and another 2,000 children to screen them for malnutrition. But after this, I thought we were going up, but we went downhill. We fell out from the fatigue. Um, the core members we had different experiences of sickness, loss. Some had ectopic pregnancies, some had miscarriages. We even lost a very valuable member of our team when I was applying for the fellowship. Um, and it was very emotional, and it was really a very difficult time for me as a leader and for everybody in the organization. But I'm very happy for this fellowship because it is a chance for me to rebuild and move forward. I've been looking for ways to improve my leadership and create this sustainable organization. And it is through the Samya Stumo Fellowship that things are finally falling into place. So by 2021, a city councilor reached out to me that because they wanted to create a city human milk bank.
Can you all still hear her? No? Okay. Nadine, we can't hear you. I think there might be a connection error where you are. We'll give her just a minute, and if not,
And
great, okay. Hi, Nadine. We just
I'm
had.
so sorry. Somebody was calling.
That's okay.
Hello, sorry. Yeah. Am I back on? Can you guys still see my screen?
Yes, we can see and hear you.
Can you yeah, thank you so much. Sorry about that. Somebody called me up. So yeah, yeah, we created a human milk bank with a lactation support center, and it is already on the works. The policy and budget to create it has been improved, but then the policies within it still needs to be built, and how we're going to deliver the services. So we really need to regroup and reestablish our goals and roles so that we will not fail in this endeavor. So the gaps and problems that we've experienced are the limitations in scaling up and sustaining our interventions. And sometimes there is a tendency for it to become personality centered because they think that I call the shots. And I wouldn't want that. I want a more democratized leadership wherein these women take responsibility in building Modern Nanays of Mindanao, because Modern Nanays of Mindanao isn't about me. It's about us. There is volunteer burnout and the lack of empowerment. There's poor leadership skills on my end, and also of others, and we lack the financial resources and the woman power to do that. So these are some of the things that my members said when I had one-on-ones with them. So because I was so passionate, it actually clouded my judgment, and they are very excited to have this strategic planning because finally I'm having structure. Because Nelisa, Nelisa is a core team member. She was our logistics head during the Marawi siege. And we went to an international NGO engagement responding to a humanitarian crisis without any training or any preparation. It was just 3 months, but it was a big learning experience for us. But it also really um, made us feel like we are not cut out to be the front lines in infant and young child feeding in emergencies. So she said that it's good that you finally have a structure. This is finally Nadine 2.0, because finally you're not gonna burn a house down. Next is Sarah. She's a mom of three. So we are all moms. She's a mom of three. She understands that we need a strategic plan because this is what she verbally said, that we have a dream up there. We just don't have the ladder and the steps to get where that is. And she said that that she doesn't know her role in the organization, and she feels like she cannot decide. But when the opportunity is given, that she knows what is expected of her, she knows her scopes and limitations, she said that it would be easy to work better. And here is Nanay Sanlin. She is a very passionate volunteer who has been with us um, since she joined the events, and she's the one who has the highest commitment. She is like double of myself, and I fully trust her. And she says, I'm ready to go and move and do the job. So what are the goals of this strategic planning? I want to build a modern Nanays that is sustainable and scalable, and it is developed by the members and not just by myself. I'd like to create a common vision, mission, goal, and strategy for us, because for the since 2015-16 up until now, we haven't sat down and really invested our time to create this blueprint. Are we looking towards the same goals and directions? And I'd like to give this sense of ownership and shared leadership to the core members. And to do that, I wish that I could scale up their skills. They can scale up their skills in leadership, organizational development, become better breastfeeding care workers. And I'd like them to become economically and spiritually empowered. And I'd like to create a blueprint for everything that we do so that we could be strategic with how we work, and we prevent the burnout, we prevent the chaotic management, as they have said during our one-on-one interviews. So how did I come up with the strategy and the design? So it started with a retrospective and reflective look on my personal experience as a leader building the organization, and how bad I felt that I wasn't being the leader that these amazing women deserve. So I have, since the fallout, since uh, the 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 complaints about um, the complaints and the conflicts, I have always asked, how can I do better? What can I do to improve? And have been searching for it, looking for mentors for it. And it was only through the Samya Rose Stumo that finally things have fallen into place. And because there was mentorship, Mira, Doc Marife, Doc Peewee helped me make my vision clear, because I have this tendency of putting on too much on my plate and thinking about too much and wanting to do so much. Starting with the fellowship, I wanted to do so many things. Do I do the modernized community building? Do I build my social enterprise? Do I build the human milk bank policy? I wanted to do all of that, but I'm very thankful with my mentors that they really made me laser focus on what do you want to do. What is the first thing that you want to build that will continue the other big things that you want? And so I said I want to put on my community builder hat so that there will be more heads, more hands to help me build that enabling environment that I am thinking about. And so the planning began. I know the goals, the problem statement, the possible solution, which is the organizational building and strategic planning. And so I communicated this intention to my members, and I gathered their interest and went to empathize with them. So I took time back in December to have a battery check and just to revisit and just have a chikahan, or like a chikahan is what we call as like a tete-a-tete, or like a talk with these members to say how they are. Where are you with regards to your commitment to the organization? And we did this in December. And then once I got them on board, I want to create a strategic planning that is participatory. We would set our goals together and create our systems together so that we could come out with a shared vision and a strong sense of ownership with well-crafted and communicated systems with streamlined processes. So who are our stakeholders? So I'd like to focus the spotlight on the white spotlights and the yellow spotlights. Um, and the circles in peach are people that we can reach out to. So the Modern Nanays of Mindanao core team members are who we are directly in contact with through this project, the Ugnayang Nanay. And we are in constant communication with the Cagayan de Oro local government unit, where we are working on creating the Human Milk Bank and Lactation Support Center, which is institutionalized and created as an ordinance by the local government unit of our city. So this is the first private public partnership that really gave mother support groups a voice in how do you want to design and run this human milk bank and lactation support center. So this is the team visiting the human milk bank in Region 10, the Northern Mindanao Medical Center milk bank. It's up and running, but then there are a lot of gaps in how they planned it. There's only one or two nurses who are running the milk bank with two doctors. They do not have time to create mother support and to give education and breastfeeding programs. And so we want to improve that with the city milk bank and lactation support center. And we are in communication with the Region 10 stakeholders like the Department of Health, CHD, Centers of Health Prevention, Health and Disease Prevention, the Department of Labor and Employment, so we could reach working moms, and even the Department of Education. And we also have partner academe in the academe who can help us with the University of USTP, who has a GAD extension research program, who actually brings us in as consultants to create lactation stations and even child minding centers. And they are also coming up with researches for unpaid care work for women and others. And there is also an academe or a group of students that we are engaging with who are coming up with a milk banking app or the mom app. We have been in contact with them since 2017. They are developing this app so that the milk donating process could be streamlined and become technology, be on an app. So we are communicating with these stakeholders right now. But after this, when we create the strategic plan, when we create the processes, we would really like to empower the other mother support groups in Mindanao. As you can see up here, we are in touch base with all the regions in Mindanao, and we have identified who the mother support groups are there. So as the pioneer breastfeeding support group in Mindanao and someone with the network and resources, I believe that when we create this strategic plan and we can then um, build the capacities of other mother support groups in the island so that the the impact of Modern Nanays of Mindanao, having that network of breastfeeding support groups are really tangible and be accessible for any mother wherever they are. So we can actually tap the national government agencies like the National Nutrition Council and the Department of Health. And we have our civic service experts like the Bayan Academy, Kalusugan ng Mag-ina, Arugaan, and we have our international NGOs which can support us and help us mobilize once we have our plan in place. So what's our implementation plan? So this is actually to get to that dream of having more breastfeeding mothers. I'd like to invest in the mother support groups and the breastfeeding champions by first connecting them to each other, building their capacities, um, doing the action that we planned on, and then finally seeing the change. So the phase one of this project is actually the connection. So it's connecting the champions with each other. So it's actually steering our vision to a common place. So it's through the strategic plan that we all sit together and share our visions and finally have this a common denominator. We identify our problems and needs together, and then we come up with a mutual understanding to do that. So what have we been doing during the phase one? It's really like talking one-on-one with the core members and the the core members and the past volunteers, um, knowing their commitment to the organization, knowing what they can contribute, knowing what they want to see through the organization. Um, and then once we know who is on board and if we have the same vision, then we go to so we go to the capacity building. Once we know what we want to do, then we build the skills so that we can carry that out. Then we carry out the action. So we do our events, we train more breastfeeding counselors, Um, and so the action begins, and we will see the breastfeeding, the change, the creation, how the creation of enabling environments finally changes um, how we reach more mothers in the community. So how do I know if I was successful in this project? So it was hard to measure impact when we're talking about empowerment, when we're talking about sustainability. How do we know that? But maybe for now, when we build this organization, I've anchored it on the framework of covalence, a study of covalence with assessing the 32 sustainability indicators of an organization. Right now, we will have that baseline if we are how many we have covered, but hopefully after the strategic plan, we can cover all 32. Then whatever we come up with, the vision, mission, goal, and strategy, I hope we can communicate this to all regional breastfeeding support groups in Mindanao to see if they are on board and if they want to um, go reach that vision together. Then, because we do not have any leadership roles or organizational structure, by the end of this project, there should be an established organizational structure with leadership roles so that everybody will know what their contribution is to the organization and they're not just mere volunteers who are dispensable. Then, once we know who are willing to work, we build their capacities through breastfeeding peer counseling, leadership training, and let's count how many breastfeeding support groups in the region were engaged in it. Then hopefully the core team members who are investing their time and talent to build this enabling environments can have just compensation or honorarium for their roles delivered. Then whatever blueprint, strategic plan, and organizational system we have created, we want to share this among breastfeeding support groups in Mindanao. And then we will measure how many pregnant women and how many breastfeeding women we have achieved when once we start delivering our projects. So we will know how since we are limited to our online support group and our online events. Now that we have a plan, now that we're going to engage in the community, in the grassroots, in the barangays, would we increase the number of pregnant and breastfeeding women that we can support? So the thing that I want from this project, the Ugnayang Nanay, the thing that I've learned is that there is strength in numbers. And if it's just me speaking out by myself, it's like pushing against a big rock on my own. Before a rock can be shaped, it needs to be constantly hit by little droplets of water before a rock erodes. And so I need more people building these enabling environments with me. And so I wish to do that through the Ugnayang Nanay project. Thank you so much.
Great work, Nadine. Since we're short of time, I'm going to open it up to just one of your mentors to ask a question or to give feedback. Dr. Marife or Pee-wee, feel free to.
I'll give the feedback. Good morning or good evening to everyone. It's been as Nadine has said, it's been uh, a challenging journey for her. Her brain works nonstop, and she likes to take on too many things. So our constant conversations have been to try to pull her back to make sure that she approaches her work with greater clarity and focus. And um, we're getting there. It's not very easy, but I think Nadine is trying very hard and has I think made a lot of progress in that area. The only thing I keep on reminding her is to make sure that the goals are clear, and that the work for the project of Ognaya Nanay will initially start small, in the sense that it will first focus on the city where they are based. That's the Cagayan de Oro City. but it will also perhaps look into what it can do to the rest of the regions in Mindanao, which is the third largest island group of the country, where the need is truly great in terms of breastfeeding and nutrition. So it's very promising. But as Nadine said, she cannot do it alone. Therefore, it's quite urgent for her to really make sure that she harnesses all of the goodwill and volunteerism and all of the people that are helping her or are interested to help her in a more systematic and organized way. So um, at least, the fellowship allows her to really take stock and think about how to do this in a more systematic manner. Over.
Thank you, Dr. Marife. For the sake of time, we're going to move on to Ruth. Ruth, please go ahead and get your presentation up. Fellows, there are some questions that might come in the chat. There's one from Anne Nadine, so please go ahead and feel free to type in response to her. Congratulations, Nadine, that was great. Okay, Ruth, whenever you're ready, please go ahead and you can begin.
Hello, everyone. All time zones observed. My name is Ruth. Okay. Hello, everyone. All time zones observed. My name is Ruth Wamboi Wagatua, Samya Stumo Fellow from Naivasha, Kenya. And welcome to my Q2 portfolio presentation. Okay. Here is the presentation outline. I hope you can see. Mira, you can see it? Okay.
Yes, yeah, we can see everything.
Here's my presentation. Okay. Here's my presentation outline. I'll be sharing on the gaps that the project I'm working on is addressing, the goals, the planning process, the stakeholders, frame implementation plan, draft budgets, project tracking, and outcomes evaluation. Fluorosis is the project I'm working on, and this is a condition caused by consumption of water with high fluoride levels, and it presents itself in the form of dental fluorosis, skeletal fluorosis, and other in vivo fluorosis such as mental fluorosis, among other if the dosage of fluoride consumed. Continuing on the gaps, fluorosis has been prevalent in our communities due to lack of investments and funding that will subsidize the costs of available defluoridation technology. The education system in these communities has not been able to equip the people on how to deal with the condition, fluorosis. And then in these communities, there is high poverty rate. Then there is inadequacy in water safety coping strategies and incentives. And then the available solutions for managing living with fluorosis are unaffordable with limited lifespan. That is, for example, the dental masking or filters. They have limited lifespan, and this creates an expensive dependency on them that falls on the local people. Okay. The other issue is expensive bone healthcare procedures, and then the unevolving water ecosystem and public health is on fluorosis. Then, despite the only available water in this area having high fluoride, the local supermarkets are mostly supplied with toothpaste that has fluoride. Then, according to a recent study by the Naivasha Sub-County Public Health Officer, the water that patients use in the public hospital to take their medicine with is high in fluoride. And this shows how systematically marginalized good quality water as healthcare is even in the healthcare facilities in these communities. Naivasha is adorned with geothermal energy because of its close proximity to a once active but now dormant volcanic mountain, that is Mount Longonot. And it is also the reason behind the high fluoride aquifers in the area as a result of its previous volcanic activity. So the blessing that is geothermal
Ruth, there might be some connection error here. I'm just going to give it 1 second for your connection to come back.
Okay.
Great. Can you hear us?
Can you hear me?
Yes, I can hear you.
Yes, I can hear you. So,
Great.
so geothermal energy production has, so geothermal energy production has always required water in the form of steam to produce energy, and therefore approaching the company to be a host partner in the investment of good quality water provision in Naivasha Okare Station initially and Menengai Station later on through CSR project stewardship is tenable and concept Mount Longonot charity concept. Samya Stumo Fellowship is equipping me with the resources and tools to turn this Mount Longonot charity concept into projects. Here are the project goals that I'm working on. Goal number 1, I hope to be equipped with funding proposal skills so that ultimately I can be able to pursue investment partnerships for the public health infrastructure solutions that I've proposed and include rainwater harvesting tanks and water treatment plants. Goal 2 is to conduct quarterly targeted public health education to the community, which I've been doing, and to empower these groups of people to equip with home policy incentives that ensure water security. Goal 3, I hope to lobby for a budgeting allocation that will ensure that bone and dental health care procedures are covered under that budgetary allocation, so that fluorosis-affected communities can reach quality and equitable healthcare addressing their primary health issue, which is fluorosis. Goal 4, to set up and operationalize an NGO. EMPAVOV is the name that was approved after search. And I hope through this NGO, I'll be able to keep implementing defeating fluorosis solutions even after the fellowship year. And the work we've also been doing in this project, we've also been writing, and we've done blog posts. Blog post for Q1, I had the opportunity to share how fluorosis affected human processes the condition, and it is in Dinkwell Institute blog post section. Blog post 2, we hope to connect the work we are doing in the fellowship with uplifting voices, the voices of women, and I'm working on mothers' role in preventing and managing the challenges of living with fluorosis. How far am I with the goals? Being equipped with funding proposal skills, I'm at the concept note stage at this point, and I hope to submit the concept note to the host partner, Kengen, by April. And I hope after submitting the concept note, they will invite me to submit full proposal. Conducting quarterly targeted public health education to the community. I conducted the first session in November 2021. We were in a small room. We didn't have much resources, but in Q2 session, which we had donated a projectile and also a filter. This is a fluoride removal filter, 20-liter household filter that I was able to give to the most needy case in the forum. And as I was doing the work, our CS for health had dropped the mandatory wearing of face masks, but I provided the face masks, and to my surprise, everybody was very enthusiastic in wearing them. And I asked them why, and they told me that life has been easier during this time of wearing masks for the fluorosis-affected humans because nobody has to judge them from face value when it comes to when they are seeking employment or when they are seeking other socioeconomic ventures. So that was very interesting, among other things that I learned from them. Goal 3, I hope to lobby for a healthcare plan that covers for managing living with fluorosis, that is Nakuru Care. And I hope to carry out research on the burden of fluorosis, cost and availability of dental and healthcare procedures in these communities. And I hope from that I'll be able to develop a policy brief as an advocacy tool in quarter 3. Goal 4, to set up an operational NGO. We already have 4 police clearance certificates. We are waiting with the application because one of the requirements of submitting NGO application is police clearance certificates from the officials. We did set up social media portfolios for Empavov in February in Facebook, LinkedIn, Twitter, and Instagram. And we hope to engage the media, that is radio, TV, TED Talk, once Empavov is well grounded. And we look forward to more exposure, pitching opportunities, and fundraising opportunities in the coming quarters. On stakeholders, Kengen is the energy company, and I hope to engage the company as the host partner by April. The community, I've been engaging them through quarterly community fluorosis sensitization sessions. Hamboa Kenya Limited is a company dealing with HAP aqua fluoride removal filters for household, communal level, and commercial technologies. They had stakeholders training workshop funded by African Water Association, AFWA, German Water Partnership, German Africa Partnership for Water and Sanitation, GAPAS. And they invited me to share my story of my story as a fluorosis affected human, but I ended up being a trainer in the training workshop on the possible ways of defeating fluorosis. And this platform also exposed me to different people who are potential partners. And one of them is the Nakuru County Wash Chief Officer, Madam Jane Muriu. And here she's presenting our NGO Empavov with a certificate for being part of the workshop. And she told me that whatever I need from our office, she's just a call away. So I'm really looking forward to submitting the proposals to her also. Continuing on stakeholders, Davies and Shatleaf, I contacted them and they prepared for me a quote for water treatment plant. Techno Plus Limited, I also contacted them and they prepared for me a quote for rainwater harvesting tanks. The Water Resources Authority, Nakuru County Department of Health, Water Sector Trust Fund, USAID. I intend to approach them after conversations with the host partner in April. And this is hopefully mid-April or May. Banks in Nakuru County have already initiated conversation with Equity Bank because they have a project on rainwater harvesting and told that they are waiting so that they are partners, proposition partners, and the capacities and resources I hope to engage them in. And Empavov, the NGO that I'm registering, in collaboration with the proposed stakeholders, we will continue implementing the projects even after the fellowship year. On draft budgets, I'm sharing these budgets because goal 1 of the work I'm doing is to develop funding proposals. And these budgets basically show the areas I need and the incentives I need to raise funds around. So one is community health literacy, that is the fluorosis sensitization. And this one is for achieving goal number 2. And this is normally what I need: meeting room rental, masks and sanitizer, writing materials, professional photographer, facilitator, note taker. We got somebody of goodwill and they shared with us projector screen and flip chart, and then equipment, transportation, drinking water in the form of liters. So normally the budget is normally around $350 for the quarterly targeted community sensitizations. For rainwater harvesting tanks, this is from the Technoplus Limited quotation. This is the incentive I really need to raise funds around. So for 5,000 liters rainwater harvesting tanks, if I targeted 1,000 households, and this includes delivery, they would sell them to me at $325. and in total $325,000. And this is aimed towards providing individual households outside the county water supply grid with good quality water. And this is to prevent fluorosis. Water treatment plant, number one solution is household filters, the 20-liter one. They go for $55 per filter. If I targeted 1,000 households, this would be $55,000. Then Davis and Shatcliffe, they quoted for me 20,000 per hour water treatment system costing approximately 100,000 US dollars. But this is subject to more subsidization because they have a program called Improving Lives Program. And once I submit a proposal to them, they can be able to even make the rate more favorable through that partnership. Then this is for setting up and operating the NGO. This is for the first year, and I include the NGO registration requirements, which includes even the police clearance certificates for everyone, the registration charges, and in total for the whole year, it would be around $39,720. And I'm still figuring out the as I do the research. How will we keep record and measure impact? We are already carrying out bi-weekly project meetings with the committee members of the NGO, where we talk and share ideas and updates, timely completion of project deliverables and sharing bi-weekly status reports, open door communication policy, especially updates on tasks, what issues the team is having, frustrations, and obstacles that need the management's intervention. Then photos, video, record, and a data bank of the project's evaluation. And measuring project success, we will be able to measure the actual outcomes against the desired outcomes. Also, the other way we'll estimate the project success is through how the forests affected humans and the forests affected communities have been empowered and evolved, and whether the solution was durable even after 2, 5, or 10 years, whether the model was sustainable. Even the attempt itself to launch or execute these projects is considered a win because this project relies on a lot of partnerships and even political goodwill. And we've come to the end of my Q2 portfolio presentation. Thank you for your attention.
Great work, Ruth. I'm going to open it up.
Yes.
Yeah, I'm going to open it up to questions from your mentors. And I'm going to go ahead and mute you for now, Ruth.
Good morning, good evening. My name is Janet, Ruth's in-country mentor. I have no question, but my comment is there's been a lot of work done to sharpen focus. We initially began with a whole lot of ideas, and so trying to look at what is feasible and based on what Ruth's objectives have been. It's still work in progress, and it's the kind of work that if we are not focused, we may not achieve much, but there's still so much to be done, but great progress so far. Dr. Anne is also around. Maybe Dr. Anne, you'd like to add something? Thanks, Janet. I think I'll just pretty much echo what you've said. As you can see from Ruth's presentation, there are very many interventions, some big, some smaller. Some may or may not be feasible within the timelines of this project. So I think it's important to prioritize and also take feedback when it's given and be open to that, because that's what the mentors are there for. Over.
Great, great. Yes. Any other questions? Feel free to post questions in the chat as well. The fellows will be happy to respond to any question you all may have. All right, up next is Ulul. Ulul, please go ahead and get your presentation up, and you can start whenever you're ready.
Okay. Thank you for the opportunity. Good evening, everyone from Indonesia. I'm Nuzul, one of the Samya Stumo Fellow, and I'm working on a project that related with health financing. This is my progress report for the quarter 2, and the title of my project is documenting the evaluation of the adjustment of capitation payment for primary healthcare facilities under the National Health Insurance in Indonesia, or commonly we call it Jaminan Kesehatan Nasional, or JKN. So this is the outline of my presentation. I would like to remind you about the gap that I want to address through the projects, and I will also share the project goals and the pillars that I want that I designed to achieve this goal. And I will also share the findings that I got from the quarter 1 and quarter 2, the action plan that I will conduct in the next quarter, and how I will assess the impact and try to build the sustainability plan. So this is the slide that I also explained in the first quarter to share about how the health financing for JKN in Indonesia. So before I started this project, actually I collaborate a lot with primary health care facilities in Surabaya for several community empowerments in improving maternal and child health. So during my interaction with them, I heard many of their story on how JKN has helped high-risk mothers with poor economic condition access healthcare services in Surabaya. So, but unfortunately, however, they also commonly share about their difficulty in managing the capitation payment that they receive as healthcare providers in JKN. The primary healthcare facilities in JKN are paid through the capitation payment, which means that they only receive fixed amount of money each month. So when it is not based on the how frequent the patient will visit the healthcare facility. It's not based on how risky the patient to be sick and will spend more treatment costs in the healthcare facility, but they are paid based on the number of patients that registered in their healthcare facility. So there is they always say to me that this very difficult for them to manage the patient to not to overuse the healthcare facility itself. So with the fact that the rate for capitation payment that provided by the BPJS Kesehatan as the agency of the National Health Insurance is have never been reviewed since 2014, since the first time of JKN implement in Indonesia. They are very conscious that the payment that they receive uh, is not comparable with the increasing number of the increasing high cost that they must spend for treating their patients. So my the gap that I want to address from this research, from this project, is that how we can ensure that the modification and the adjustment of capitation payment has accommodated the appropriate incentive and compensation for primary healthcare facilities to be able to serve people with different healthcare needs, like high-risk mothers, elderly patients, patient with chronic disease under the JKN. So they can serve them with high care quality, but they don't have to experience with difficulty in managing their operational costs. This is the goals that I want to address in this project. My goal is to provide evidence regarding the fair payment for capitation payment for primary healthcare facilities under the GKN scheme. I work a lot with the primary healthcare facilities, and they say to me that they are currently working to negotiate with the BPJS Kesehatan Surabaya to 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 urgently implement the more fair capitation payment for them, and also try to redistribute the number of the imbalance between private and public primary healthcare facilities in Indonesia. To achieve this goal, I plan to use three pillars. The first is I would like to document the evidence to support their negotiation to have more fairer capitation payment through scientific research, and then I will communicate the research result to the that I'm working with is mostly they are women, and they are from clinicians that do not know well about what is health financing, how to manage the capitation payment. So they need to have a reference or reading source that can improve their capacity in managing payment that they receive from the JKN itself. And the last one, the pillar three, is I would like to institutionalizing the health final research in the IC Hub. The IC Hub is a research group that I built with the other young researchers in Surabaya. So we learn together about health financing. Health financing is very complex. So I and my research group really eager to have a mentoring session with the expert in this health in Indonesia, and I get it from this fellowship. This is the fellowship activity that I plan. We already passed the first quarter and the second quarter, and in this third quarter, I will continue the result the plans. Uh, I will more workly on the documentation, the research result that I already conduct in the second quarter, and try to communicate it in accessible language for the health manager that do not have background in health financing through the blog post itself. And I will also work with the stakeholders, such as the Association of the Primary Healthcare Facilities in Surabaya, to provide them with evidence on how an evidence that can support their effort in negotiating with the BPJS Kesehatan Kota Surabaya. So I will like also share the findings that I got from the study that I've already conducted in the first quarter and the second quarters. Like I have said before, that I learned a lot from my mentor about the capitation payment under the GKN, and through their mentoring, I conduct these two studies in the second quarter of the fellowship. The first study, I try to answer how the ideal capitation payment have been conducted in Indonesia by comparing the regulation of the GKN and the basic concept of the capitation itself that already mentioned in the textbook. And then I try to analyze how the impact that already recorded in the previous research in Indonesia. I should emphasize only on this third third characteristic. There are all of them have different impact. I found the difference between the regulation and the basic concept, but I think I will only explain in this session is only about the risk adjustment calculating capitation payment. um, so I found that in the book they say that it must be calculated by considering the risk, the health risk that owned by the patients registered in the primary healthcare facility. But in the JKN, it the risk of the patient is not considered to determine how much money that will be get by the primary healthcare facility. So it brings an impact for the primary healthcare facility. Like they say, they have difficulty because actually there are different utilization rate between the age group where the elderly and the newborn have used the primary healthcare facility oftenly than the other age group. And then in the second study, I used case study by using data from the BPJS Kesehatan Surabaya to capture how this different age group will determine the risk of patient to use the healthcare facility and spend more capitation money that received by the healthcare facility. So there is a difference based on the analysis. We know that there is a difference utilization rate between the age where the newborn and also the elderly have increasing utilization rate. And the other one is also that the utilization rate in the private primary healthcare facility is always lower than the public primary healthcare facility. So it will be addressed in the next quarter on how we approach them to help them with understanding the capitation payment utilization. Um, the second study consists of two parts, but the second part I'm still analyzing the data, so I could not share the result right now, but I can show you that from the second part, I will calculate and provide how much how adjustment rate that should be provide to make a fairer payment for the healthcare facility. So I also talk with the stakeholders. The association said that they really need support to negotiate with the BPJS Kesehatan. They show me about what happens in their in what difficulty they found, and I also talk with the two private primary healthcare facilities in Surabaya, and they said some experience that show their difficulties in managing the capitation itself. So based on the studies that I have conducted and progressing to be finished, I plan to have an intervention that will, I hope, will be useful for the primary healthcare facility in Indonesia, in Surabaya. So the implementation plan, which consists of three main pillars that I suggest to achieve the goals. So the first one, I would like to document the research and the scientific publication through the national journal published by BPJS Kesehatan is a way for me to communicate the result directly to the BPJS Kesehatan. And then the second one, I will communicate the research to stakeholder and population to a series of blog, so they can have an an explanation about what is the capitation, how to manage them, what kind of difficulty that they probably face in managing their capitation through this blog series. And the last one is that I want that my research group also can make it a sustainable collaboration with the primary healthcare facility in Surabaya by conducting financial research and community services in this issue. This is the impact assessment and sustainability plan in the first years of this fellowship. I put I targeted some outputs. For instance, for the pillar ones, I will publish an article, a blog series that will be published, and by creating research roadmap and help the primary healthcare facility to create the risk management plan. I hope that they will have guidance on how to manage their capitation payment while the still struggling with the negotiation with the BPJS Kesehatan. So I think this is the last slide that I have. Thank you so much for listening to my presentation. Thank you.
Congratulations, Ulul. So any of Ulul's mentors, feel free to get off mute and share your thoughts or ask questions.
Okay, good evening, everyone. My name is Iko Safika. I will go first. I'm sorry to inform you, but Prof. Hasbullah, the main mentor, cannot join because he has something to do. But nonetheless, I also have worked with Ulul over this past maybe 3 months or 4 months, Ulul. I have no question, but comment and suggestion. Thank you so much, Ulul, for your excellent work and progress. Great presentation. We have spent time actually to shape your topic and focus analysis. So it's so good to see all this progress. And congrats for being able to work on policy focus project. The adjustment of capitation payment at primary healthcare, no doubt is very important work. As your slide also showed that our national health insurance practice is quite complex. With the current payment mechanism. So your work can inform policy at the national level and is also aligned with the new presidential decree to optimize the implementation of the national health insurance. And I also really like to see how you provide the contact of the situation, the current situation right now, and how the relationship between the key stakeholder and the health provider. And one of the strength of your study is the utilization of mixed method, because you review the literature and also conduct this case study by analyzing both secondary and primary data. So you can compare and contrast the literature and the practice of capitation payment at your selected primary healthcare in Indonesia. The area of improvement included, you need to provide a clear recommendation. As you know, there are at least 3 key players in our national health insurance: Ministry of Health, Health Social Security and Administration Agency, and also the National Social Security Council. Therefore, the recommendation can be made applicable and clearly stated which level on or key stakeholder that you are referring. It is also essential to have a strategy for disseminating the finding beyond writing up the manuscript itself. As you also mentioned, you want to institutionalizing health financing research in SCHEP. I bet it's your research group. And our project here in Indonesia also focus on health financing activity. So we can also discuss presenting the finding to relevant stakeholder, including how you disseminate the funding to your participated primary health call. Or also your finding can also be shared with our team and partner who work on the same topic. So the knowledge sharing strategy can be conducted here. I will stop here. We look forward to continuing working with you to ensure you achieve your goal. Thank you. Over to you. If there's one more mentor, if Mbak Epi is here, she can also chime in. Otherwise, congrats again. Thank you.
Great work. Anyone else? All right, feel free to post questions in the chat as always. The fellows will be happy to respond to any messages in the chat. And then we will move on to our last fellow, Martha. Go ahead and feel free to get your presentation up. Congratulations, Ulul, that was great. Martha, whenever you're ready, go ahead.
Thank you, Mira. Good evening, good morning, everyone. My name is Martha. I'm one of the fellows from the Philippines. And today I'm going to be presenting you my updates on my project entitled Institutionalization of LGBTQI plus Health in Universal Healthcare. So this is going to be my outline. So I'm going to be doing a refresher on my problem statement as well as my project objectives. I'm going to be also presenting the stakeholders that I engaged with and the activities I conducted this quarter, and the results of those activities. And lastly, I'll be presenting my plans for quarter three, including a timeline and the sustainability and impact of my project. So, in recognition of the various problems that are encountered by LGBTQI Filipinos when accessing healthcare, including the orientation of health programs towards cisgender and heterosexual individuals, limited understanding of LGBTQI health needs by health workers and the health system, stigma and discrimination by health workers, and the lack of specialized or tailor-fitted care for the community. As a public health practitioner and as a trans woman, my passion has always been to serve my community. And we'll be seeing later that these problems are just the tip of the iceberg. So the objectives of my project is mainly to develop a policy framework on the promotion of LGBTQI health in the Philippines. This quarter too, I took a deep dive with my fellow community members to understand our complex health needs and the social determinants and other factors that affect our health. And in quarter three, I'm actually planning to engage with relevant Department of Health offices and key experts to help me build the policy framework. So these are the stakeholders that I engaged with. I interviewed community and members, LGBTQI individuals, and at the same time, formally organized civil society organizations. So I interviewed 8 individuals covering the different identities of the LGBTQI, and as well as civil society organizations. Built and formed by intersex individuals, trans men, and also actually lawyers and um, LGBT rights advocates. Aside from the interviews, I also did a review of literature, particularly looking into frameworks, understanding the effects of social structures, interpersonal and individual factors on LGBTQI health, country examples on the establishment of LGBTQI health and existing LGBTQI health related frameworks. So this is part of my literature review, and this is what I actually used to make sense and to package the different themes that I was able to gather in my interviews with the LGBTQI members. So essentially, what this says is LGBTQ health issues are deeply rooted in social justice issues. Big words such as um, misogyny, sexism, homophobia, transphobia, heteronormativity, and cisnormativity. Um, that actually translate or manifest into real life experiences of stigma and discrimination, shunning of peers, parents, verbal abuse, harassment, and also systemic forms like what I've mentioned, um, cisnormativity or heteronormativity that manifests in the current state of our health system right now, which actually affects this community's social determinants of health, preventing them from being able to receive good quality education or preventing them from getting good paying jobs in order to support their lives and also their health. So given the complexity of the different aspects of or the complexity of the different factors rather that affect LGBT health, there is really a need for an intersectoral, multifaceted approach in order to protect and promote LGBTQI health. So as I mentioned, these are some of the themes that came up during the interviews. As you can see here, there are actually a lot of recurring themes, starting from the health outcomes, experiences of violence and sexual abuse, depression and other mental health conditions, and also unmet healthcare needs. You also have different vulnerabilities and susceptibilities like addictive behaviors, depressive symptoms, lack of appropriate medical or social services, feeling of social isolation or lack of a community, again, mental health problems. And of course, the social determinants of health that I'm talking about, experiences of unemployment or underemployment, and feeling that sexual health services are heteronormative. And then lastly, real life experiences of stigma and discrimination, parental peer rejection, verbal abuse, physical abuse, difficulty obtaining acceptance from families, etc. And all of these root from these social justice issues. So this is just a continuation. And what's interesting here is, aside from the recurring themes, you actually can see very specific issues or themes that come up, especially specific to transgender and intersex individuals. For transgender people, particularly the lack of knowledge of the health system and lack of access to gender affirming therapies. And for the intersex, it's really the lack of knowledge and standards of care for managing intersex patients, especially since globally there is a huge problem of um, corrective surgeries um, being done with or children who are intersex. But again, there are a lot of recurring themes similar to what was presented earlier. And again, all of these root from the social justice issues. And on the other hand, the community members I interviewed actually mentioned a few examples of promotive systems for LGBTQI health. Particularly, the formally organized civil society organizations are able to form or forge community partnerships with health providers. Others were able to experience inclusive health services, particularly for HIV. And then it was mentioned across the board that it really helped them when they were able to find their support systems either within the community or from non-LGBTQI peers. And then lastly, I was actually able to interview a successful case of changing his gender marker here in the Philippines. It was the first time that happened. He won a court case. He's an intersex patient. And I was able to interview him, and essentially he was really happy that he was able to win that case and was successfully able to change his gender marker. And as communicated by a lot of his community members, it really gives them a lot of hope. So after doing the interviews, I also looked into the establishment of LGBTQI QI health in more mature systems, including the United States, Canada, the United Kingdom, Sweden, and the Netherlands. Um, and I also put the progress of LGBTQI health in Asia and the Pacific, particularly for the Philippines and and Thailand. Particularly the inclusion of LGBTQI in national policies or national strategic plans. And what I've learned from the experiences of other countries is number one, the importance of the enactment of gender equality or anti discrimination laws. Based from what I've read from those countries, I believe that's what actually started these initiatives, or rather, consolidated and strengthened LGBTQI health initiatives. A second learning would be coverage by social health insurance. Again, as communicated by community members, especially the trans community, they're really having a hard time accessing health services because of lack of subsidy or lack of financial support or financial risk protection by government. And so this is a really critical step in order to promote LGBTQI health. In other countries, um, federal governments would actually ensure that the private health insurance won't discriminate against the LGBTQI community. And then lastly, this wasn't a part of the literature review, but actually a learning from one of the webinars I attended. And it's the critical role of medical societies in the development of standards of care and clinical practice guidelines, especially since I've been learning that while there may be um, issues across the board or services for some of the LGBTQI members are actually not very specific to them, but the issue is more on the inclusivity of the health service. You actually also have identities, particularly the trans community and the intersex community, who would need very specialized care. And so medical societies really play a critical role in pushing for LGBTQI health. And then these are other existing LGBTQI health related frameworks. So the social ecology model considers the relationship of LGBTQI individuals to their environment, to their families, to their social support networks. The minority stress model related to the earlier framework I presented, consider the health disparities that arise from stigmatization of the LGBTQI, the life course perspective, which considers health needs and experiences of the LGBTQI across different life stages, including significant events like discovering one's sexual orientation, gender identity, and expression, coming out to peers, to families, and building families. And then lastly, the intersectional perspectives, which considers intersections of LGBTQI individuals with dimensions of inequality. And this is very important to consider given that a lot of the problems that are faced by the LGBTQI are also experienced by different minority groups such as non-Catholic Filipinos, members of indigenous communities, etc., etc. So I actually came up with a conceptual framework to kind of consolidate the learnings that I was able to um, get from the interviews and also the literature review that I did. So it mainly at the top is really legislation to facilitate um, the protection of LGBTQI Filipinos, at the same time, the recognition that we deserve. A few examples would be SOGI equality or anti-discrimination laws, marriage equality, or at least recognition of civil partnerships, and gender recognition by the state, which would actually trickle down to um, your social determinants of health. And um, it's really critical that before you even go to the health service, or another dimension outside the health service, would be initiatives that would facilitate social protection, protection in schools and SOGI education, protection in workplaces and SOGI training, and community involvement. And then at the service delivery, um, again, my theory of change is a policy. And so I believe it really starts with ensuring that policies and programs are inclusive to the LGBT community, which would actually translate to capacity building initiatives, um, financing, and at the bottom would be um, your foundation of inclusive leadership and governance, which would all hopefully translate to inclusive health services and the development of standards of care for the LGBTQI, which I really hope that would translate to better health outcomes and better quality of life. Just to highlight service delivery, it's not a trickle down. Rather, your service delivery or the gaps that we see as public health professionals would actually inform um, intersectoral or multi-sectoral initiatives that actually work on the social determinants of health, and both of which would actually inform the development of legislation. So, so that's actually my updates for quarter 3, and these are the things that I plan to conduct in quarter 2, and now in quarter 3. So after essentially building this portfolio from the data that I've gathered, from the conceptual framework, my problem statement, and my objectives, I really I'm hoping to present to the different DOH offices to initiate conversations, and to increase awareness of the different health needs of the LGBTQ and what role they play in this initiative. And then after having those conversations, I then be able to build the policy framework for LGBTQI health promotion. And then lastly, I would be coming back to my community and validate the policy framework that we were able to build through FGDs. So just to provide you with some specific DOH offices that I plan to talk to, primarily it's the Health Promotion Bureau, because it's essentially a policy framework for LGBTQI health promotion. Um, Next would be the Health Policy Development and Planning Bureau, which actually houses our Gender and Development unit. So as a backgrounder, because of the Magna Carta for Women, all national government agencies here in the Philippines are actually mandated to allocate 10% of their budget towards gender and development. And what we've actually started to discuss with this team is um, we recognize that there's actually a lack of appreciation of gender and development within offices. And now we're thinking of possible ways on how to increase their appreciation of GAD, and how can we provide support to them in their development of their annual gender and development plans and budgets. Of course, training towards inclusivity among health workers must always be emphasized. And so I also plan to talk to the Health Human Resources Development Bureau, and then lastly, other offices that actually play a role in the development of standards of care, and at the same time, um, aside from initiating conversations and promoting or initiating discussions toward LGBTQI health within the sector, there's also a need for us to ensure that the DOH as a workplace is LGBTQI inclusive. And so that's why I plan to also talk to with our HR, the administrative service. So this is just my timeline. Again, quarter 3 will mostly be talking to DOH offices, and then afterwards developing initial policy recommendations. And quarter 4 would be the validation of the framework. And then in August, my final presentation with Thinkwell. So in terms of sustainability, because is an existing gender and development technical working group, there's actually an opportunity there to facilitate the discussions. Again, the theory of change of this project is to really come up with the policy framework, and hopefully after the fellowship, I'd be able to issue it out as an administrative order. And lastly is being able to embed LGBTQI health under Health Promotion Bureau. So this office actually becomes the champion for the portfolio. And then lastly, as for the impact of my project, more than anything, it's really raising awareness on LGBTQI health and the specific health needs of this community among health policy practitioners and decision makers in the DOH. With by the end of the fellowship, the actual policy may or may not see the light of day, but at least I'm starting conversations with these technical offices that would actually help me in issuing out that policy framework, and in the medium term, catalyzing various initiatives within the DOH and our local counterparts, and as well as collaborations with non-government partners. And then lastly, this is just the beginning of, as I would always say, a lifelong work. And so by doing this project, I really hope that I be able to provide proof of concept for other national government agencies here in the Philippines for the promotion of LGBTQI health and LGBTQI rights, as well as to other countries. That's the end of my presentation. Thank you so much.
Great work, Martha. I'm going to open it up to your mentors and anyone else who would like to ask questions or give thoughts.
I
It's
guess.
getting.
Oh.
Sorry, go ahead.
No, I would like you to go first, but I at some point, if you want to look at or tell us how likely do you think it is that this, as you refer to them as this office, I guess it's where you work, that they would become a champion for these ideas. But please, your mentor should go first.
Well, what I was just going to say was that because the issue related to the LGBTQ community is complex and diverse, I think that the plans to focus on the Department of Health, precisely for the reasons that Nadia mentioned, that there are enabling factors that will allow progress there. I think is a rational way to approach this problem, particularly because the focus is the health framework to provide and address the needs of the sector, the LGBTQ community. So you're correct that being within the Department of Health helps to facilitate these conversations, and knowledgeable about how the processes are helps to be able to move certain things. So we did talk about this, Martha and I, and we think that to be able to focus in order to actually be able to show, as she said, some proof of concept that can maybe open up other avenues with other agencies to also address the other needs of the LGBTQ sector. Over.
Great. Any other questions, thoughts? Again, feel free to put it in the chat. Go ahead, Nadia.
I guess you don't need to respond now. Maybe it's just food for thought, but this money that is for gender equity, or is it for gender equity? That's what I was kind of understanding.
Yes.
You just said gender, but how does it, how do you continue to promote not just that money to be spent on LGBTQ plus issues, but also for women because they're consistently discriminated against? So is that part of your approach?
Yes, so that's actually what's happening now, Nadia. A lot of the initiatives that are budgeted from that Gender and Development Fund is towards cisgender women. And I'd always tell this to the offices that I encountered. The Philippines has actually made great strides in the promotion of women's health, but of course, there are still problems. But there's a more mature um, appreciation of women's health here in the Philippines. And what I would always tell my colleagues is how can we expand that advocacy to also include gender and sexual minorities such as the LGBTQI community. Um, I guess to close my response, the goal is not to um, take away from women's health, but essentially the goal is to promote women's health side by side with LGBTQI health, because at the end of the day, feminist theory and queer theory fights for the same things, and it's for gender equality.
Thank you. That's a very thoughtful response. I appreciate it. And I appreciate all your work and the work of all the other fellows. Since I didn't get a chance to mention, most of all, I am so grateful for the mentors, because without the mentors, this could not function at all.
Great. Well, we're here to close this meeting now. Thank you all, as Nadia just said, both mentors and the fellows. Fantastic job. This meeting has been recorded, and we'll have an opportunity to send it to everyone who was unable to be present to listen. Overall, please email us if you have any questions. You can feel free to send me any questions, and I can forward it to the fellows. And yes, so we're excited to see how Q3 goes, fellows, and once that's over, we'll have a big culminating presentation around the end of Q4 to share all of your progress in this test phase. Congratulations, celebrate today, and thank you all for being here. Bye.